Hoorah. Uh,
There we go.
hey, thank you. Appreciate it. All right. So today's IQuIC meeting again is being recorded for later reference. Just for a couple, I guess what the house cleaning, I guess term things for the meeting. As normal, the department sent out a meeting invite. That meeting invite does include some attachments in it. So each participant or health plan should have our health plan contact list. And just a reminder that the health plan contact list was kind of created so the department and HSAG, our external quality review organization, can kind of know who to contact concerning certain audits or projects that we're doing. So again, we ask that the health plans, if you do have a change in staff, that you submit, kind of do an update, either delete or add that name in on your section or your tab of that spreadsheet, and forward that information over to Holly at HSAG. You can CC me if you remember, and then Holly will go ahead and she kind of maintains the master list for that one. So that's how we kind of manage. It's kind of a main tool we use to manage who should be notified about what concerning the projects that we're doing. So again, and that's one attachment in there. Some other attachment in the in the meeting invite, the progress report. Progress report, it kind of lists kind of a summary or some insight into all the quality activities that the department and HSAG are conducting as well. So, for instance, if you're curious of what's going on with the quality of care grievance kind of audit or project we're doing, you'll see some notes in there, or you'll see some additional notes about our compliance site reviews, performance improvement projects, or the CAPS projects as well. Again, for all the projects we're doing. So that is also provided for the participants of the IQuIC meeting and our health plans. So that's just an FYI on that as well. So I did want to just point those things out. And today, and also just for everyone's reference, this is a open to the public meeting. IQuIC is. So basically anyone can attend today's meeting. I just ask that if we do have any new participants for today's meeting, if you'd like to comment or ask a question about what today's discussion, just let me know. You can shoot a message over in the chat. Just kind of identify who you are, and then I'll sure to find some time for you to speak up and address some issues. So I think oh yeah, I think I got one other thing here. As health plans, as you may recall, Barbara McConnell with HSAG, she's kind of, I think, retired, but I think she's still working with HSAG on certain for some limited projects. I wanted to let everyone know that Barbara should be taken off of your contact list. I understand she's still receiving a number of the emails or follow-up items from health plans when you're responding back. So at this time, I did have a request though. So if you are doing some follow-up communications with the department or HSAG, if you're copying Barbara McConnell, please just make a note to kind of remove her off of that communication. So I really appreciate that. Okay, so let me hear. I think I checked off everything here. Did I get all of your kind of some of your issues as well, Holly? Notes?
Yeah, that was great. Thanks.
Okay, all right, great. All right. Well, going down the list, let's go over to the next slide, please. Okay. Department's mission, our mission, improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide. Today's agenda. Well, we're going to review the November 2023 draft minutes. That's kind of the last time we conducted an IQuIC meeting. Then we're going to jump into a quality of care grievance web intake form demonstration. Helen Desta, our supervisor here at the department, is going to kind of lead that topic for us. Then we're going to have a kind of a discussion on CAPS, and Russell Kennedy with the department is going to kind of lead that discussion. And we're expecting health plans to kind of share some of their insight or address some of Russ's questions on that one. And basically, we're moving to department health plan updates and reminders. And that's just basically an opportunity. If the health plans have any of the latest and greatest they'd like to share with the department, it'd be a good opportunity to share that at that time, or any department staff, if you have any updates you'd like to share at this time, feel free to chime in during that topic. And again, as I noted previously, this isn't open to the public meeting here, so anyone can attend. All right. And let me just check some additional notes here as well. Then we can move over to the next one. All right. Sheila, were you able to get in okay? If you're on the call? Okay. All right. We'll just wait. Sheila's got to be logging in. Okay. With that said, let's jump over to the next topic. Review the November 2023 draft minutes. So, and again, that's another additional topic you should see in the meeting invite. And in the minutes, basically from our last meeting, we did have a managed care entity health equity plan update. And our diversity director, Aaron Green, kind of did a presentation at our November meeting. And I didn't, so the minutes there do note some of that communication that we had. And I just want to know from this topic at our March IQuIC meeting, we are expecting Aaron Green and Dana Beatty to kind of do a presentation on the health equity plans that the health plans did submit. So that's just an FYI for you there. But as in regards to the draft minutes, I didn't have any changes for that one. Then also topic 4 at our November meeting, we kind of just had some updates and reminders. Russell Kennedy kind of shared some input on the status for the caps, any possible caps changes or what was coming up down the pike. I understand that Russell has already addressed that, and the communication has gone out to the health plans on that issue. But in regards to the draft minutes, I didn't receive any changes for that. And that was kind of basically what we had kind of discussed at our November IQuIC meeting. So at this time, I move to a motion to approve the draft minutes for our November meeting as they are. If there are any objections, please state them at this time. Well, once, going twice, and gone. All right, thank you. I will go ahead and move forward and approve the minutes and get them posted to our IQuIC website on the department's link. So thank you. So let's jump over to the next slide. Quality of care grievance web intake form demonstration. Helen, Ms. Fraser, are you there?
Yes, I am. Thank you, Jerry. Thanks everyone for joining us today. I'm Helen Desta-Fraser. I'm the quality section manager here at the department. I wanted to take some time to have Slalom, who is our third-party Salesforce vendor, walk through and give a demonstration around our quality of care grievance intake form. As you recall, in the contract amendment, this intake form would be the template that you would all use to submit a potential quality of care grievance. That was the first deliverable in the quality of care grievance contract amendment. We want to allocate about 30 minutes to walk through this step by step. Please feel free to raise your hand if you have any functionality or cosmetic questions or concerns that you would like to bring up. I do ask that any policy questions around quality of care grievance be saved for the end of after this intake form has been demonstrated. I feel like it would be appropriate to have this at the last agenda item at this IQuIC, if that's okay. So I will take this time to introduce William Davis, and Bruce Gordon, who has been working really hard these last few months to get this intake form up and going. And I will say that we will be sending you over the link to this intake form after this meeting in the meeting minutes. And I see a hand from Micah. Did you have a question before we get started?
Just that this is the training is gonna be distributed in other venues other than this live session?
Yes, it will be distributed if there's any additional questions on how to use the intake form. We are recording this for reference, so if there are staff members that are unable to attend today's meeting, they can also reference the recording. Okay, William, take it away.
All right, thanks, Helen. Good morning, everybody. William Davis. I am leading the slalom team that has been partnering with Helen and Sheila and team to bring this intake form to life. If it's okay, I'm going to steal the screen share so I can kind of show how this was built out. Just give me one moment. All right, can somebody confirm that my screen is in fact showing? It should be showing what looks like a web form with the IQuiC logo on it.
Yes, it is showing. If you can possibly zoom in just a little bit, that would be great.
Okay, let me check here. All right. How does that look?
Great, thank you.
All right. So this is the web intake form that we've been building up over the last few months for the parties here to submit potential quality of care grievances. I'm going to probably refer to those as QOCGs for short as we go through this demonstration. But the link to this, as Helen mentioned, will be distributed with the minutes of this meeting. So you'll have that handy and available. But kind of starting off here, we have this text here at the top that really, if there's any issues and experienced in submitting this form, there is contact to reach out to Sheila with the QOCG team at the Department of Healthcare Policy and Financing with what you're trying to submit and if those issues are preventing you from submitting the details of your grievance. So kind of starting off here, the first section here is really just more of the high level information on the QOCG. You'll see that leading off here, we have today's date will be populated with the date that you are accessing this form. Then at the top, we really kind of drive two different avenues in this form, whether it's related to a specific member or not. It will show as defaulted as yes, that it's related to a specific member, or if it's not, you can additionally select no. When selecting no, I'm just going to temporarily do that here. You'll notice that some of the following fields here, the member's state ID, the member's first and last name, the member's date of birth, those will all become optional fields. But if you're selecting yes, that this is related to a specific member, those fields will be required to submit the form. So we'll want to make sure that we have that information. Kind of following from there, next question here, we have the QOCG subtype. It defaults to physical health, but there are other options here, behavioral health, dental, pharmacy, etc. And you are able to multi-select, but it does require that at least one value is selected here. And you'll see a lot of the fields here being called out as required with this red asterisk, just so users are better aware of this. Navigating on down, then we get into the potential QOCG submitted by. So how are we describing the party that's raising the awareness or raising this grievance? And there's different ways to describe different buckets or categories. We want to have a better feel for the entity that's submitting this. So whether it be a parent, sibling, member, guardian, RAE, IQuiC department staff, provider, county, legislator / advocate, ombudsman, other or facility staff. And if other is selected here, we do provide another field here to further describe, just basically providing additional detail as to the who's submitting this potential QOCG.
William, I just wanted to interrupt for just a second. Lynn, you brought up a great question. So there is a drop down. I don't believe it's shown here in this demonstration, but there is a drop down of all of those options that William has stated.
Yes, that is a good point. Some of the Microsoft Teams limitations. Sometimes those drop downs will not show on what I'm presenting. But yes, it's a drop down where you can select a single value from some of those that I read. But apologies that Teams might be limiting us on seeing that. So since we do have yes selected as related to a specific member, we are seeing these members' state ID, first and last name, and date of birth required. When we go to enter in the state ID, it is going to force the format of a state ID, so that being a capitalized first letter followed by 6 numbers. So just input into that format. I'm going to enter just some test data here so we can better recognize it as we kind of clean up our system afterwards. So input a date of birth. For the date of birth, you can either select from the calendar here, navigate to previous years, months as they're laid out, and the calendar will kind of lay out with the year and month that you select. So we'll just, for an example, March 6th, 1991 is what we'll select. Additionally, you can type in through a keyboard essentially the date. However, there are only a subset of formats that manually typing in will be accepted. So we provided some guidance here on other date fields. Either use the calendar icon, so clicking into the field here, how we selected previously, or you can type in the format of MMDD YYY, which the example of how that would be read would be something like 01/01/1980. Once we get past those few pieces of member information, we want to provide details behind the entity, the individual or entity that's under investigation. So the first one being the name of whether it's provider, facility, MCE, or department staff. So just add in some dummy data here. And then we want to also include the address of this facility or this provider. Additionally, yes, definitely want to make sure that we are completing this field if it's in regards to a provider or facility. So we'll just add a value in here. And then some contact information regarding that entity that's under investigation. So email or phone. And then phone this will force both formats. An email will be required to be at something.com or .org, and then a phone number will be required to be the 10-digit phone numbers that we use. Then we get into describing other pieces of information, name or address of where the QOCG occurred. And then this field is especially important when this differs from the address that's provided related to the facility, the provider, the MCE that's under investigation. We want to make sure that we're including that information here. So we include additional help text if different from provider, facility, MCE, department staff address. Moving along, we have a field here that is available if we want to input a case number or a ticket number that we have already on file that's applicable to this QOCG that we're submitting. So you can definitely reference that here. And we want to identify the dates of the QOCG occurrence. We require a date of initial occurrence. But if it's a repeating issue, we offer up to specifying 2 different instances where this happened. And it operates like the date field we saw previously. You can either click in to select a date from a calendar, or you can type it in manually with that format we reviewed. I will note we did kind of guide on this format here, but once you click out, it'll format it into a more legible format for that. The last field in this section, we have the QOCG risk level. Those values, and I'm clicking into a drop down again, those values that we can select from are low, moderate, high, or undetermined for a QOCG risk level. We included some help text here in the eye icon. If you click that, pop-up will display describing what low would entail, what moderate would entail, high, and undetermined. So those are some of the initial details we collect around the QOCG. Then we kind of get into a field section where we want to know about you or the individual that's submitting this form to us. So say my name is John Smith. That's where I would enter that here, is into the reporting entity name / title. So my name is John Smith, and I'm the entity that's reporting this QOCG. So who am I representing? I'm representing either an MCE, or this is another drop down that I'm clicking into. So the options here of entity reporting the QOCG are MCE, CIRs, the IQuIC County Relations, IQuIC Department staff, Ombudsman, or other. And then depending on what you select, it'll change kind of how these next two fields are required. So if you select MCE in this pick list, we then have the next field specifying the plan. And again, it's a drop-down pick list with several values, all the RAYs, the CHIP Plus, DentaQuest, Health First Colorado, and so on. But if you select in the entity reporting the QOCG, something other than MCE, will show that organization is now required. And we want to further describe the organization that is behind reporting this incident, especially if different from the MCE plan name. Let me go ahead and enter in a value here, reporting organization. And then how can HICPUF get a hold of me? How can the department get a hold of me as the individual submitting this form? This is where you want to provide your information upon submitting this form. So phone number that they can reach you at, and then also an email that they can reach you at. This email is especially important because upon submitting this form, a confirmation email will be sent out to the value that's provided. So I'm just going to put in my slalom address. That's especially important because we'll receive the confirmation of this submitted form with the ticket number for any sort of future reference that we may need it for. Going further on, we want to specify, does this QOCG require a signed release of information? We have the values yes, no, or unknown, where you can only select one, but some additional help text here. Release of information required for individuals 18 or over. From there, we get into sort of categorizing the quality of care grievance that's being submitted. Some help text here. There's several values, and they're all set up to where you can select more than one. But you must select at least one to be able to proceed and submit the form. So just go ahead and select some values here. And you don't have to select one in each category. You can select just one across all three categories. Those categories being the treatment / delivery of services, concerns and complaints. We have patient safety and outcomes. And we also have professional conduct categories as well. And then furthermore, there's a description field down below that gives you the ability to provide more long form descriptions of what the incident was, what the concern is that's being submitted. I'll just enter in a brief test value there. Get down to the bottom of the page. This is where you can either opt to include any file attachments along with your submission. So it's a toggle that will tell you active if you've selected to include attachments, inactive if you are not including attachments, and then some guidance on kind of what the next steps are here. So clicking next, it's going to start processing your information with department. If the toggle is set to inactive, the submission will be final. So how it is now, clicking next down here to the bottom right will finalize the submission. But if I were to click active as if I'm going to submit files or attachments along with this submission, I'm going to be directed to a file upload page with further instruction, but I'll also have the ability to navigate back to this drafted form in case there's any revisions that come to mind. So I'm going to go ahead and navigate to the next page and act as if I'm uploading files and kind of show you how that looks. So this directs me to the file upload page. Before we kind of get into uploading files, I am going to show that I'm going to upload one here real quick just to kind of show how this saves your progress across both the pages. But then say I realize there's a piece of information in the form that I meant to include. I can select previous down here, and it navigates back to the drafted values that I've previously input into the information into the form. And I want to change, let's say, I'm going to also specify and categorize that access and availability is relevant to the category of grievance this should be. I want to make sure that that's included before I proceed forward. Coming back to the file upload page, you do see that the file that I previously selected to upload is still showing as attached to this submission. But before we kind of talk about the file upload page, questions about the previous form page before we kind of take a look at file uploads.
I do have a question about the release of information. You have it designated that that's only for 18 or over, but in the state of Colorado, there are specific laws, you know, for 15-year-olds as well as 12-year-olds who are receiving behavioral health treatment, that they can receive treatment without their parents' knowledge. And so I think that we might want to look at that maybe per state guidelines when we would need a release of information rather than 18 and over.
Thank you, Lynn. We will look more closely at that. If this does not apply for a specific instance, you can always choose the unknown, but we will look closely at that field.
Okay. Thanks. And just a quick you have Northwest Health Partners as a drop down. It's Northeast Health Partners.
Oh, okay. Thank you for that, Kat. Thank you.
Yeah, you
I
bet.
apologize about that. We will definitely fix that.
Okay. Now, the other question I have is the date of the second occurrence. Wouldn't that go to the state? And would that be like, you know, if there is our usual protocol for, I guess I'm just wondering with that second occurrence, if a member files a complaint and we resolve the complaint, the next level would be the second level review at the state level. But if a member is filing a complaint for a second time, I don't know when we would use that other category, if that makes sense.
Yeah, I don't suspect that other category would be filled out. There is, however, we do get potential quality of care grievances internally, and that can be through a critical incident report. So if that would be an example of when that second occurrence may be documented, and that can be a way for us to track that this is a repeat issue that we need to look more closely at.
So would HICCUIC be filling that out as well? If there was like it came to them, would they fill that out so you guys could track it?
Yes.
Okay,
It would
gotcha.
be HICPUF or, another agency that is tracking that. They can put that for our records to ensure that we know that we've seen that this is a repeat case.
Gotcha. Okay, that's good to know. And then,
Yeah.
of course, we probably wouldn't have a case ticket number, so we would just put unknown or not applicable for that.
Or leave it blank. Because
Leave it
that is
blank.
not, it's
Okay.
not required.
Okay.
Some of the plans may have their own internal case number or ticket number, so you feel free to include that on there.
Okay.
Or leave it blank. It's not a required
Okay.
field.
And then this second, where it talks about the provider facility. What if there really isn't, like, because we can take a complaint about anything, from a member, and it doesn't necessarily involve a specific provider or a certain, team. They're just, a member may just be upset about something that's kind of, that doesn't involve a certain provider, and that's a required field, all of those things. What would you recommend?
So if the member is expressing a dissatisfaction of if it's not necessarily a provider, but it's the facility in which the provider that they were seeing resides in, that would be where the applicable, that's where you would fill that out. The location of the facility that the member is expressing dissatisfaction.
Okay, thank you.
Absolutely. And I know that there's many questions in the text. I did want to answer Logan. This will be for both quality of care or potential significant patient safety issues. We're kind of, that's the same definition that you see now in the current contract as a quality of care and grievances. So we will be expecting that this is the form used for grievances and quality of care / potential significant patient safety issues. For those that are what we're defining as potential significant patient safety issues, so not reported by a member or member advocate, in the beginning of this form, there was an option to click yes, that this is regarding a member, or no. No would be that potential significant patient safety issue that's not reported by the member or member advocate.
Helen, can you
have a
explain that to?
clarification? Right, you just said something that I think needs clarification. You
Yeah.
said this is for grievances and the potential significant event.
Yes.
Did you meant, I'm wondering, grievances that are quality of care in nature, so QOCGs, are we to use this for all grievances? Because a lot of this wouldn't apply to random grievances that have nothing to do with quality. So I just wanted to make sure I understood.
Yes, so the expectation is any grievances in which a member is expressing dissatisfaction. That is not adverse benefit determination related.
So that would be then most.
As and potential quality of care / potential significant patient safety issues. I'm using both because the current contract says quality of care. The contract amendment is saying potential significant patient safety issues. The expectation is to be for all investigations.
So Helen, this is Courtney with Caroline. Maybe I just missed something, but you said this would be for reports that come from a member or an advocate. A lot of our quality of care issues come from internal or other providers. So if I heard you right, you said only when they come from the member or.
No, I apologize if I wasn't clear, but this would be from a member advocate, or any potential significant patient safety issue. So coming from a provider, facility, the plan. So it would be coming from those avenues as well. Member and member advocate would be specific to just grievances, but it can come from other reporting entities.
Thank you.
It would be really helpful to have all of those terms defined, because there's real differentiation within the nuances of these. And I want to make sure that we're adhering to your request.
Absolutely, Micah. Do you mean more defined than it is in the current contract amendment? Because we do define each of these terms
Yeah,
there. Okay,
mhm.
Yeah, I just
all
kind of wanted to
right.
speak on that as well.
I do want to hold other questions that are not specific to this web intake form for later in the agenda. But if there's any questions regarding, the cosmetic look and the functionality of this form, if please feel free to ask that now.
I have a question just in relationship, and maybe I missed this, but when it is ultimately submitted, is there something that comes back to us to like whoever submitted it to confirm that it has been received? And does that confirmation include like a ticket number? Because I know currently if we submit the paper form, Sheila responds and kind of gives us a case number to associate, but do we get some kind of feedback that when this is successfully submitted and what information is included there?
Yeah, absolutely. William, would you like to answer that?
Yeah, so in this field section here, contact information of entity reporting the incident. So this is meant for the person that is filling out this web form. So you would put your name here in the reporting entity name / title, other pieces of information regarding, the entity that you're representing and specifying either the MCE plan or the organization you're representing, and then contact information to get a hold of you for any sort of additional detail that the department may need. This last field in this section, reporting entity email, is where you would want to put your email in here, and you would receive an email confirmation of this submitted ticket. And it'll give you the ticket number. We haven't gotten quite that far to show that piece off yet, but I'll pull it up once it's received and kind of show you what that email looks like. But yeah, exactly to your point, it's a confirmation that this has been submitted, and it'll give you that ticket number that this is creating.
So I have a quick
William.
question.
Great, that's helpful. I'm just thinking is the additional deliverables that kind of proceed from this one include the QOC summary that'll, I'm assuming, need to link back to the case number. That'll be helpful. I'm just looking for more information as we put the whole process together of how we'll submit the next pieces of the deliverable.
Absolutely. So Catherine, you would use the case number that you receive to then send a secure email to that quality of care inbox to send over that QOCG summary. And I know there was a question about if there's a limit of how many staff members are able to enter the data or use this form. This is a link that can be shared with your grievance department and quality of care department, because I know some plans have separate departments, and they can all have access to use this link. And this is just a web link that they can all use to submit any potential quality of care grievance.
Okay.
So another question, this is a lot of information to do in the original notification. Because I'm guessing we're going to try to do it all in the first day, but we have up to 2 days to get this in. So a lot of this is going to be preliminary or frankly incorrect. I saw someone else in the chat asked if this information is able to be updated.
It is able to be updated via email communication through the QOCG inbox. Sheila then can go into the Salesforce application and update any changes.
Thank you.
We understand that this will be preliminary information that you receive.
This is Stacy from Colorado Access. So sorry, just to clarify, I think you lost me a bit at that sending an email. So we have to fill this out. It like once we submit, it generates a ticket number that we then have to email. Is that correct?
No. So it's only when that investigation is resolved, you would then send an email of the QOCG summary. And then with that email, you can refer to that case number. Hope that
Oh.
answers your question,
So you
Stacy.
you wouldn't just attach the summary in here and then close the ticket. You have to like,
You would just attach the QOCG summary in an email and then Sheila would update it to this specific case. Or if you were to do the update in this intake form, it's essentially opening up a new ticket, which is not what we would want. We're trying,
okay.
because we'd essentially try to close that ticket, if that makes sense.
Well, I thought you could update it, like, because Kim just asked if you could, like, if this is final, and you said it, you could go back and check, because like information changes, dates change, blah blah blah.
Yeah, internally we can, so you would just send us the update via email and we can update that on our end.
Okay. And then another question. So for when so like grievances, like, traditional grievances don't run through a medical director for scoring. And so I don't know how like our grievance customer service department would assign a risk score to a grievance because it's never ran through a medical director for scoring.
Yeah,
Those would
so
just stay as like risk undetermined.
undetermined or low, depending on this. If it's something that William, can you hover on that on that risk level? Yeah, so if it doesn't contribute to the unsafe environment and it's very unlikely to directly contribute to harm, that would essentially be a low. But if you can also do undetermined at this time.
Yeah, I don't, I appreciate that clarification. I don't know that our customer service team would like feel comfortable scoring these just because they don't have, like, that's really not within their scope. And so but I appreciate that clarification. I think that's, I guess just one more thing. So per like the definition of a QOCG, they're very like member and specific incident focused. So at the top, it says like, does this relate to a specific member? Yes or no? I can't remember exactly what it says. Related to a specific member. So within the definition of a QOC, it doesn't really like, the definition doesn't relate to like incidents that don't involve a specific member.
So as
So
a reminder, the QOCG is an umbrella term to encompass both potentially significant patient safety issues and a grievance. Grievance is specific to a member or a member advocate expression of dissatisfaction. If it's related to a grievance is when that yes would be chosen, related to specific member. If it's related to a facility, it would be a no.
Like a facility, like broadly?
Yes, so if it's a provider or facility, if it's a provider, filing a QOCG on another provider, that is, for example, maybe a potential significant patient safety issue that would be appropriate.
Okay.
All right.
Helen, this
I
is
think
Heather
this-
from Rocky. Would we be able to add that to that related to specific member, just some clarification there? Because I think that's going to be a little confusing, especially, because you're going to have different people filling this out. And so I think if we had a little clarification on that, that would be really helpful. Like exactly what you just said. Yes, if it's related to a grievance with a member advocate, otherwise it's no. Right.
Okay. Yeah. So like an eye icon where we can hover. That's something.
Yeah,
it may take some.
exactly.
Yeah. It may take some time for us to do this as Slalom is ending their work with us. So we
Sure.
may have to go through our internal process. But absolutely, that's something we will document on our end, and we can look
Or
into
even a
updating that
crosswalk
form.
or something. Yeah, even a crosswalk to the different fields. I mean, just something. I agree with what Stacy said that, there's going to be a variety of different folks who could be filling this out. So I think as much clarification would be really helpful.
Absolutely. We will work on that. It may not be ready by the time of contract
Sure.
amendment execution, but that's something we will keep note of internally and work on getting that fixed.
Perfect. Thank you so much.
Absolutely. Thank you.
All right. I think we do have a little bit more we want to show here. So definitely can revisit other questions after we kind of get through the next couple of items for this form. So we're ready to, we've populated a bunch of information regarding the potential QOCG, and we want to attach some files that accompany and help supplement the information that we're submitting. So I've navigated here to the file upload page with some text that will better direct you and kind of how to navigate this page. So uploading all required documentation. You can either click the upload to select files local to your machine. So I'll show you that here. So that is the upload button. Or you can drag and drop over the or drop files button. So I'll drag a couple there as well. Give me a moment. You got to make sure it won't drop the files anywhere over the page. You'll need to drop it over the actual button itself. And then as you continue to attach different documents, they will list here within the page. So you can kind of visually confirm that these are, in fact, what you intended to upload. If you, for whatever reason, happen to attach a file that turns out you did not want to include with this submission, we do have these trash can icons that you can click, and then it'll remove that file that you don't want to include in your submission. But whether you're doing the upload files button or dragging and dropping, you can upload up to 10 files per action or at once. But then you can repeat the action if necessary. But we want to ask, please limit your total files to 25 or less. And then some guidance as to the supported file types. So pretty standard file types to include with submission, doc, PDF, PowerPoint, XLS, different image file formats, GIF, JPEG, PNG. We want to also call out the feature, this file upload feature, not something that's as available on mobile devices. So best experience in submitting this form will be from a desktop or a local machine. And then just some disclaimer text as well. This web form and any included attachments provided to the Colorado Department of Healthcare Policy and Financing. These are confidential and intended solely for the use of the individual or entity to which it is addressed. The information contained herein may include protected health information or otherwise privileged information. Unauthorized review, forwarding, printing, copying, distributing, or using such information is strictly prohibited and may be unlawful. And this is all pertaining to the Health Insurance Portability and Accountability Act, or HIPAA. So this is set up with the robust security that Salesforce offers that this web form sits on. So now we've included all the attachments that we desire, and we're ready to submit. This will finalize the submission of this information. And as Helen had mentioned earlier, this is just preliminary submission. As sort of the ticket kind of progresses and we find out more information, they'll be working to update the information on their end, kind of as this evolves and goes through to resolution. So this isn't final, but this is just from a submission standpoint. This is the initial submission.
Thanks, William. And I do want to add that uploading files is not going to be a requirement for that first initial intake form, as we understand that some may not have anything to upload. However, there are some cases in which members or for example, let's say like a case manager at a facility sends an email or a letter to have their case or their investigation wanting to be looked at. And that's something that we would like to be uploaded in that initial intake form submission, if you do have it.
Yeah, that is a good add. But so you'll see here, once you're kind of done going through the submission, you'll come to this landing page, thanking you for your submission. It does have your ticket number here. Can definitely write that down in other notes, but now I'm going to switch what I'm sharing. I did receive a confirmation email regarding this submission. So I want to show you what that looks like. Came through to me probably less than 10 seconds upon hitting submit. 1 second, and I will pull that up. So this is the email that I received confirming my submission of that web form. It uses the name that I entered in my contact information, thanking me for the submission, gives me my ticket number for future reference, and so on. That is sort of the experience behind the web form submission. So like Helen is suggesting, there will be further correspondence after initial submission, sort of as the information evolves.
Thank you, William, for that demonstration. I know there's a lot of questions that, and I see a lot of hands raised. Is there any additional feedback or questions that you have around the cosmetic look of the form or the functionality of the form, as we have Slalom on the call?
Are
I
we
put
able-
a note in the chat that the entity, when you're asking for a person's name, so how it's written, I think there's going to be people who put the business name where you're asking for the person's name. I realize 2 or 3 lines below that, you get to do a drop down for the business name, but it might be better to say reporting person's name versus entity. I think that will reduce some of the confusion.
Thank you, Kim. Yeah, we struggled with how to name that field. So we appreciate the feedback. We're definitely open to suggestions on renaming that to make it make more sense. Any other questions regarding the web intake form?
Not necessarily the web intake form, but William, I'm wondering, are the Rays or whoever is filling out this information, would we have the ability to go in and look at all of the quality of care grievances that we submitted for the month? Like, do we have access to that kind of reporting or to look at it? Or is that a functionality of this?
So there is not that sort of permission set up with this web form. So there would not be visibility into the list of tickets that you've submitted for the month or really even previously. It's really set up as if you're a guest user that would not necessarily partner with 100% on these tickets after your initial submission. But that is something that's out there. It could potentially be built up, further down the road. It's just not how this is set up.
Right. So we'll still need to do and that's not a question for you. We'll still need to do our internal tracking just for the state and, federal guidelines. The other thing I just want to make note of is that at the top where it talks about member, yes, no, the one thing that I do remember from the initial trainings is that a member could potentially make a quality of care grievance. They can make a concern or they can make a complaint where they say, I have a concern about a quality of care issue. So it's not necessarily, if it's a provider, it's a quality of care issue versus it's a grievance. If it's, it could be both, right? And maybe that's a
Right.
question for the state. Yeah.
Yes,
Okay.
that would be a question for the state. And that is where the confusion lies around a quality of care and a grievance. And that was the purpose as to why we wanted to have one term to encompass both, because we do recognize that there are some quality of care or potential significant patient safety issues that do come from the member, which would then by definition be a grievance. And I think that's where that confusion is because we in the current contract have it separated out in different sections. And so that's our intent to combine those efforts. We understand that it can be both at times. And actually, majority of the time it is both. I will say, our hope is right now we are just getting the form up and running. Our hope in the future, though, is to be able to pull a report by Ray to say these are how many potential quality of care grievances that have been submitted. These are the trends that we're seeing, and this is just the first step into that. All right. Not been able
Helen,
to see
this
all
is
of the
Courtney.
chats. Hi, Courtney.
So oftentimes Lynn and I will work together because she has a grievance issue, and then it turns into, like she was saying, a quality of care issue.
Mhm.
By definition, it's two different things. So are we expected to create this form twice? Or how does that work if we're both looking at it just from a different lens?
Yes, so if it is a same issue, but the origin is coming from a member or a member advocate, you would choose that yes. That yes, related to specific member. You would choose that, you would click on that circle, and then you can work together with Lynn on submitting this form.
Okay, so I think I'm just a little confused. So a lot of our quality of care issues are about specific members, right? So
Yeah.
we would click that naturally anyway for most of our quality of care issues. But does that mean that we're creating two of these forms if Lynn's team and our team on the quality of care side are working on it? Or do we just determine who's going to be responsible for that? Because I'm concerned about when we get audited.
Right.
That
Our hope is
we
it's
might look like we're
one
missing
form.
something.
Our hope is it's one form being submitted, and it's up to the plans to work internally on how that one form, if it's the same issue with the same member, that is going to be that you'd be working together with the different departments to submit the form.
Okay, thank you.
The reporting entity in the bottom, William, if you can scroll down. Yep, that reporting entity is the person submitting the potential quality of care grievance. So submitting this form, because that person would then be getting that email that William stated that says that the submission has been completed and here is your ticket number.
One way to
Do we have a rough-
clarify that would be to say contact information of the entity reporting the incident to the state. Because I can see how people might think reporting the incident to us, right? So maybe just adding those couple of words to the state or something like that.
That's a great suggestion. I think that would provide more clarity.
Is there a rough idea of when this will be implemented and we should start using this site?
Yeah, so the form, as of the 22nd, it's ready to go live. We obviously are waiting for the contract amendment to be executed, but we will be sending out the link to this form in the meeting minutes. And Audrey will also be adding the link to the external SharePoint page. So please feel free to start using this form. Obviously, the expectation for the plans is it's not required until that contract is executed, but if you would like to test trial it, please do.
And Helen, just to be clear, even for potential safety concerns that we wouldn't necessarily investigate fully, let's say, for example, a member has a suicide attempt offsite, hasn't been to services for a month or two, you still want these forms for those kind of incidents as well, even though maybe we know we're not going to do a full investigation?
Yes, we would like to have insights of all of these circumstances so we can be able to better track any trends or any possible interventions that the department needs to be involved in. And the amendment, it's my understanding that the amendment is planned to be executed in the next couple of weeks or so.
Helen,
Sorry,
hi,
I
this
just
is
saw that
Kendra
question
Rocky.
from
Just
Lynn.
quick question for you. On our next reporting period for technically appeals and grievances would be in April for Q3, which would be January 1st through March 31st. Are we expected to still use our old reporting and then start, doing everything from like April 1st? Or I'm trying to figure out like when the cutoff is, from the old way to the new way. Because I think we need some clarification so that we can get some runway built with our teams that do this reporting for us.
I completely understand that. I don't want to give an arbitrary date, but it's obviously all dependent on the execution of the contract amendment. We would ask that you follow your current process now. When the contract is amended, that is the start of using this intake form and this new QOCG process. So if, let's say, for example, the contract is amended in March 1st, then that's when you can, for your grievance and appeals deliverable, you can end that at March and then start this process.
So then we would report our grievances the old way for all grievances 1/1 of 24 through 3/29 of 24.
Yes, do you mean 2/29?
Correct.
2/29 of 2024.
2/29. That's what I meant.
Yeah,
Sorry.
and that is only, if the contract is executed.
Right.
So it's just subject to that contract amendment execution.
Okay, that's helpful. Thank you. I
Yeah.
just wanted to understand that process. Perfect. Thank you.
Yes, and Elizabeth, that QOCG summary would be sent via email, encrypted email to the QOCG inbox. Sheila will then upload that into that member or potential significant patient safety issues, that case into Salesforce. So then we would have a full summary of what happened and how that QOCG was resolved.
Okay, thank you. And will you send us that email that we should be using?
Of the QOCG? Absolutely. We can, I can make sure that's included in the meeting minutes. It has been sent over in the past, but we'll make sure that that's included in the meeting minutes.
Okay, thanks.
Yeah.
This is Courtney again, and I'm sorry, this might not have anything to do with what we're talking about right now, but when we talk about having to report up some of those incidents that we would consider not an incident or likely not an incident, are we still going to be required to do the acknowledgement letters and all of that with it as well as we did our typical QOCGs when we open investigations?
Yeah, so you would submit this form for any of the incidents. If it's resolved, then you would just send out an email, an encrypted email to say this is the resolution with the requirements that's in that QOCG summary, the expectations and the contract amendment. That would be for all investigations. I hope I answered that question.
Yeah, but we wouldn't have to send, we have to send an acknowledgement letter and a resolution letter for incidents that we open and we investigate. So would we now have to do that for, like I said, like a suicide attempt that happened with a member that's not active in services off facility site? Do we still need to take those added steps now as well?
Yes, the expectation would be those steps would be added for that example. And the summary is it can be the same as the resolution letter to answer Dawn's question. As we still have Slalom on the call, I don't want them to stay on while there's a bunch of questions. Is there any last minute feedback questions about the form? And if not, we can have Slalom jump off.
Helen, it's Jerry with a lot of questions. So just wanted to note that there were a number of a ton of questions. I think Sheila was addressing as many as there, and I believe you were addressing some of the questions noted in the text. So for the draft for the minutes, I'll try to just list the questions. And again, I think it'd be probably best if the health plans should probably use the recording as a kind of a major reference. But if there are some questions listed in the minutes that they didn't get a response to that they really want to find out about, that they follow up directly with you or Sheila. But again, I did have that question about sending out the link. Are we confirmed with sending out the link directly, sharing that in the minutes, or basically I do have the contact list of all the QOC staff for the MCEs, and I can submit that link or directly just to them versus having it out there. But we could probably talk about it a little later if you like. I think you're on mute too. Thank you. Yeah.
Thank you. Sorry. My only concern to send it to only the QOC contact list is there may be more individuals with the plans that work in the grievance department. So it may be, I think sending in the meeting minutes might be the most appropriate so everyone has access to this form, as well as the QOCG inbox.
Great. Hey, thank you.
The good call out. Thank you for that.
And I think there's pardon for jumping in. I think some of those, I saw some questions of if HSAG auditors for a QOC piece have been notified of this process and all. And I believe just to answer that question, yeah, there's HSAG staff that kind of audit the health plans for QOCG projects. Yeah, they are aware, but it's still an option, you know, basically if they need to get follow-up information or work with the health plans, it's still expected that the health plan would work with the HSAG auditors versus you know, HSAG having to go to this form and so forth to get information. But just thought I'd throw that piece out. And so it's just the questions I just had for right now. So thank you.
Thanks, Jerry. All right. I know we have other agenda items. We will be answering all of the questions in the chat. I'm so sorry we're not able to address all of them at this time. William and Slalom team, thank you so much for the demonstration. We really appreciate it. For all the plans that have staff members that were unable to join this call, please reference the recording. We also do have internal staff members that can do an ad hoc demonstration of this intake form. Catherine, I think you see your hands up.
Yeah, I was just curious on the agenda time as we transition, if we still have some more time for discussion about the process and the amendments before moving on to the other topics of our agenda.
Absolutely. I would hold that off until after that CAPS discussion because I just want to make sure there's enough time for that. And if we do have additional time remaining, we can definitely talk about the QOCG process and amendment.
Great. And it's, you know, because time is just in short supply these days. I think it's fair enough to say that given the substantial change, both in the amendments at the last moment and just that the amendments upon their execution imply, I think perhaps we do need another separate specific ad hoc meeting outside of IQuIC for those that would be implementing this to be able to really dig in on the nuance and the compliance that we'd like to be able to provide given the significant changes to this process that we're about to implement.
We can definitely get that set up.
And would that also maybe help with troubleshooting of like any issues that we're having with this new process, right, Helen? We would appreciate that. Thank you.
Essentially a good technical assistance call. I can see that being appropriate.
That would be great. Thank you.
Yeah.
And just another opportunity for us to maybe formalize, I know it's been in the chat quite a bit, just a process flow and a real desktop procedure guide that would aid in our implementation because, you know, sometimes in this conversational back and forth, it is a little tricky to figure out where the expectations are landing. So we want to make sure we have really clear understanding of that.
Yeah, we can definitely work on revamping that flow chart that we made initially now to include this form. I would say the only big change is probably the timeline that and the definition. Those are the big changes from our last discussion at the previous IQuIC. We presented at the MSB for an emergency rule to try to get that timeline to 15 business days. Unfortunately, that was not approved, but we are still going to be working to try to get that 90-day change. However, we just have to follow the standard rulemaking process. So it's still something that we are looking to maybe, if it gets approved, we may have another contract amendment in the future.
Is there going to be a time for us to actually talk through the contract amendment? So not just the procedure and notification tools and that kind of thing. I would say that a lot of us have noted substantive issues, including from our legal teams around the contract. So when will we have that opportunity? This seems very unilateral, and I think we really do need to talk through some of the substantive issues.
Yeah, we can work on getting something set up outside of the IQuIC to where we can get that contract amendment discussion. We can get that happening. I will say we are at a timeline in which we do want to get the contract amendment executed, and we have provided just a lot of opportunities to where we can get feedback from with the contract amendment, and we did address most of the feedback that was brought up to and raised to the department.
But it does seem like there was feedback and there were changes made and then they were changed back. And so that's where a conversation would be helpful. And there's statutes that are listed that are actually incorrect. There's just things that we want to help with that we're not sure that there's still an opportunity.
Yeah, so I think it sounds like maybe in the next week, we should probably get something set up before a contract is executed to ensure that everyone feels comfortable with the new recent changes in regards to the timeline. I would suspect that that's the biggest concern with the plans on this call, that with us reverting back from 90 to 15. Sorry, did someone say something?
Sorry, it's me.
I think there's the timeline issue plus the member notification issue for things and having to, the peer review issue and then giving very detailed information that may be coming out of peer review. So there's just a number of pieces that I think we just need to make sure that we're crystal clear on with the department.
Okay. We will work on getting something set up for the next week so we can get the contract executed. Mm-hmm.
It's now 15 days, even for potential safety issues, right? Open to close.
Yep. You got it, Courtney. All right. Thank you, Slalom, for all of your help. We really appreciate you demonstrating the web intake form, and any additional quality of care grievance questions, we will hold it until the end of this meeting if we have time.
All right. Okay. Well, thanks, everybody. Have a good day.
Thank you.
Okay, thank you, William. Okay, Helen, sounds like we're okay to move on to the next topic. Is that correct?
Yes, we are.
Okay, thank you. All right. So if we jump over to the next slide, Department and Health Plan staff discussions on consumer assessment or CAPS response rates. Russell Kennedy, are you there?
Yes, I am. Can you hear me?
Yes, sir. You sound good. It's all yours.
All right. Yeah, I had sent out an email a couple of weeks ago after getting some information from HSAG regarding a large increase on undeliverable mail from our CAPS surveys that have been going out. And we were curious if the plans are experiencing the same thing. So I sent that email out for the plans to talk to those who would be in the know. And I was wondering if the plans had anything to report on the return rates they're getting on their mailings. So open up the mics for whoever might be able to comment on that.
I'll go. So I know the rates are required to submit to the state a member change report. And for raise 2 and 4, all of the member address changes that all the return mail gets placed on that form. So I'm wondering if you could capture that information by looking at that member change report that all the rays have to send in. I'm assuming that that's a common way to include return mail on that form.
I'm not familiar with that report. Could you tell me who you send that to and the name of it again?
It's called the member change report. And I don't know the exact, it's uploaded to the Move It, files for the state. So I don't know which team at HICPUF actually reviews that, but it is submitted by the 5th of, I think it's the 5th of each month. And it includes all member death or all member change of addresses.
And your
so the member change in circumstance report, Russ.
Change in circumstance. And
yeah, member change in circumstance report. Go ahead.
And you believe that returned mail would show up in that report? Or is this just when you are notified of a change?
Correct. When we're notified of a change of address, we have to report that in that report. And we let the member know so that even though they reported it to us, they have to make sure they update their PEAK account or contact their county to officially change their address.
If we do report,
if you got returned mail because you did not have the correct address, it would be reflected in that report.
For raise
no,
2 and
return
4
mail is not. I don't believe.
Okay.
Lynn,
oh, that's interesting.
Return mail?
Yeah, we do. Yeah, we put all the return mail on that report, like all where we can't. So that's interesting. But we do include all return mail on our reports.
And is it under that heading as returned mail? I mean, is it, or is it?
It would be categorized. Yeah, it's categorized on raise 2 and 4. And I think that, looking at the total population with, the number of pieces of return mail, and it depends, because I think some rays may be sending out more correspondence than others. So,
right.
Yeah.
Any other comments from the plans?
Hi.
Looks like, there's 2 hands raised. I'm sorry, but go ahead, whoever's speaking.
Hi, this is Lauren from Colorado Access. So our facilities team has not seen any changes in the amount of undelivered mail that we print in-house. But that being said, most of our large-scale mailings, like new member packets, things like that, are done through a marketing vendor, and they're sent under a nonprofit rate, and return service isn't a service that the post office provides for that.
Okay. Another hand raised.
Looks like Kimberly has her hand raised.
Is that who it is?
Yeah. So I have some data on undeliverable mail like through the first week of February on our caps. I guess what I don't know, Russ, is how that compares to 2022. So I may have to ping that team to see like what our undeliverable percentages were for 2022. But what I'm seeing on the child side is only around 6%, and on the adult side is only around 10%. So it's not an alarming number on our end, but I can try to get the 2022 for comparison if that would be helpful.
It might be interesting if you could email me with that.
Okay.
Is Destiny Meyer? Are you on the call, Destiny?
Hey, Russ. Yes, this is Destiny.
Oh, thanks. Good. What kind of rate are we seeing on returns? I know that you had presented this, observed this here recently.
Yes. So we're seeing pretty much around like a 10% rate as well. But compared to how many surveys we're sending out, that's quite a large number. It's in the thousands, like, so that's actually kind of high for us.
Okay. And we're maybe not even seeing all the returns if an entity is using the service, the mail service that doesn't pay for returns. So it could be even higher for the plans than they're seeing if that's the case across the board. All right. Anyone else have any comments on that?
I didn't see
well,
us, Jerry. I didn't see any questions in the chat, Russ.
All right. If any of you dig into this any further, go ahead and feel free to direct email to me about what your findings might be. I think this trend is concerning from last year because we had kind of solved that problem a little bit by getting the plans to submit the sample frames. But it looks like we've taken a step in the wrong direction this year. I'm sure there could be a number of factors responsible for that. The changes from COVID going off where people couldn't be evicted and now being able to could be a factor, I'm thinking, but certainly open to any other ideas other than that. I can pass this back to Jerry.
Yeah, Russ, this is Micah, and that's what I was going to say. The PHE unwind, I wondered if the department has done any analysis on individuals who have stayed on Medicaid versus those who have rolled off, because if you took a sample frame from before the PHE unwind, that's going to be an essentially now inflated number population. So I wonder if the department has done any of that analysis as well, because that could be the answer or a clue. Thanks.
Yeah, I'll dig into that on our side. Thanks, Micah. All right, well, I appreciate any input that you guys provided or can provide in the future. At this point, there's not a whole lot we can be doing about it. The sample frames are what they are, and we'll just, I guess, hit hard on the phone calls.
Okay, Russ.
Is there a question that just popped up or a comment?
There was something that popped up. A person raised their hand, but I think they dropped it. And I'm looking in the chat right now, and chat's still referring to some of the previous topics. So at this time, I don't see any. Yeah.
All right. Thanks, Jerry. Thanks, everybody. We'll just keep slugging along and let you know if we find out anything on our end.
Okay. Hey, thank you, Russ. Appreciate it. Okay. So we jump down to the next topic, please. Oh, department and health plan updates and reminders. Me personally, I can't recall anything other than health plans. You should kind of, again, reference the progress report that I shared on the meeting invites for the IQuIC. That'll kind of give you some, hopefully should share some insight on where we are with our projects. Any other department staff have any updates they like to share, or any health plans? Do you have any updates you'd like to share? Okay, so let's go over to the next slide. Public comments. Okay, again, this is an open to the public meeting. Anyone at this time, new staff or any of our, citizens of the state of Colorado or anyone else, I guess, if you had any questions on today's topics or you'd like to share some insight, please feel free to do that at this time. Okay. All right, yeah, we had about, I believe, about 92 callers in today's call, so I didn't get a notification that we had any new participants. So I believe that kind of ends the scheduled IQuIC discussions, but I think we had a request to want to go back to the previous topic on the demonstration. So Helen, are we still addressing questions on that one, or can you?
Yep. So we would like to hear any comments. It looks like we have about 30 minutes. I know that there was a new contract amendment that was sent back to the plans with the message that the emergency rule was not approved to extend from 15 business days to 90 business days. So the department has that they're wanting to change the contract to have all investigations resolved within 15 business days. We understand that it's difficult to do, especially in those cases that are very complex, but we are offering that opportunity to, if there's issues such as medical record procurement or other things such as that, then we will grant an extension for 14 calendar days as it is in the federal regulations. We do hope to bring data back to the Medical Services Board to show for those that are complex, we understand that that can't be done within 15 business days. So we would like to have that tracked on our end to bring that to the Medical Services Board as another way to hopefully get that approval of 90 business days. So I do want to give that update. And I know we just discussed that we can have another meeting around next week to have those legal conversations and any big process changes that you all would like to get addressed. Courtney, I see you have a question about how many extensions can we request. At this time in the current contract amendment, it only states for the one, that one extension. So it can be that 14 calendar days. If there is additional extensions that are needing to be requested, it's not specifically noted in the contract amendment, but we can discuss that internally as needed.
I think this is Courtney, Helen. I think that we probably need to discuss that pretty quickly because I can't speak for the other raise, but getting a case open and closed within what is that, like 29 days? I mean, we average between 27 and 32, and that's on our good quarters. So I think that probably needs to be a discussion pretty quickly, else we're going to be very out of compliance more often than not. And that's concerning.
Okay, yeah, we can definitely have that discussion. I will note that this is the reason why the department pushed to have an emergency rule change. And because we understand that a lot of these cases, they don't get resolved within the time frame that the rule has currently. So we can definitely be more specific in that contract amendment as to how many extensions are granted and what's the length of time.
A chance that we're going to get more than one extension? Because like I said, even 29 days is pushing it.
Right. Yeah.
To get it through committee and all of that. So that at this point would be my biggest concern. I'm okay with putting in extension requests, but if I only get one extension request per case, that could become problematic pretty quickly.
Yeah, I can see that. I would definitely advocate for more than one as well. So I will definitely bring that up internally and we'll have that discussion.
So kind of going down the same route really as Courtney as well as Micah in the chat, you know, it just seems like a simple change of wording would make all the difference. The rule is specific to grievances, and I think all of us agree to the 15-day rule for grievances. And so if the TAT could be for grievances, and then once we figure out a grievance should fall into QOCG, then a new timeline, because QOCGs, I mean, we could do a non-par, not very good investigation and stay in timelines. No one I've talked to from any of the race has any interest in doing that. So if in the beginning of the amendment, it just separated the two and then brought the two together and talked of the timeline specific to grievances, which is how the rule was written, I think that would solve the TAT issue.
Yeah, I agree, Kim. We obviously do not want, we want investigations to be thoroughly completed. So those that are quick resolutions, we would like that to be done at that appropriate time frame. I will say though, we did initially try to separate the two. We separated the grievances from the quality of care. We had different timeframes, such as 15 days for grievances, as what the rule states, and 30 days for quality of care. And that also created more confusion with the plans. I'm not sure if you recall about a year ago when we had the discussion, by separating them, that also resulted in confusion. And what we're trying to do is not have as many confusion as we have right now in the current contract. And we want to hold the plans more accountable in the space so we get more insight on what's going on. Like I mentioned, a lot of these quality of cares can be grievances too. And so if they are complex cases, it does take more than 15 days to get to that resolved and to even get medical records, for example.
Which I would say you're right. In most cases, QOCs take more than 15 days because in almost all cases, I would say probably all, we do have to get those records. And so we're dependent on the provider organization. Right. And so if a large number of grievances then turn into those QOCGs, we're set up to fail with the 15-day. Is there no way to imagine keeping them separate until the rule can be changed?
At where we are at this time, I wouldn't advise that they're separate. I believe it would be more clear to have all investigations done within a certain time frame with that opportunity of extension, and that can provide more data for us to collect for a potential rule change.
Kim, do you want to?
Well, right. Yeah, Micah, right. Because the data you're talking about is our not fulfilling the terms of our contract. And no one is comfortable with that because that would be the data that we can't close these within 15 days and 29 days is not realistic for a portion of these. And so that's the data you would be presenting is our not fulfilling this contract. And I think from my discussion with the other CMOs, no Ray is at all comfortable with this.
And Helen, this is Micah. You aren't wrong that the clarity of language in the contract when you put them together, would appear to be clear. And I love clarity. So, that's, I think, the crux of this discussion. I think the cost is on what Kim was saying. It's on our reputation. It's on these people who my staff works so hard to do the right thing. And I'm not sure that the cost of us failing is worth the return on this investment. I think that that's an important consideration because we do want to be compliant. We have experience to show that we are not able to get medical records. It's just out of our hands. It's not even something that we can process improve. And so, it really puts us in a bind.
Yeah, I do want to address that comment is with the department, we are not wanting you all to fail. That is not the intention of why we are creating this new process. Why we want to create this new process is so we can collect and measure, report, and analyze all of the insights of these known quality of care grievance events across the state. We want to ensure that we are identifying all of these risks and trends so we can improve member safety. And I think we can all agree with that. What we also know is that the timeline that is put upon us with the Colorado rule is not a reasonable timeframe to complete any of these investigations, or at least most of these investigations, specifically those that are very complex. I think a lot of the questions is around the definition. And I would argue that a lot of, again, these quality of cares that as you've defined it in the current contract, it can be confusing, but they're all essentially, well, not all of them, but most of them are grievances. So they are reported by the member or the member advocate, meaning either way, at this time, you would have had 15 business days. If you wanted to be compliant with what the state has, you would have to be completing those within 15 business days unless an extension was granted. So this is an existing process. And I think by having this more clearly outlined on the expectations, then we can see what better way we can to like improve the process or just get better insight what's happening. I just want to echo that I don't want you all to fail. We want you to be compliant. We understand that there's issues with getting medical records. We do want to assist in that and help with, especially with the non-contract providers, we want to assist in getting those medical records. And that is a big cause of the delay of not getting these resolved within 15 business days.
So Helen, this is Courtney. I think my issue is not even if I have a provider that has a hard time getting me medical records, but even in a best case scenario, I get a quality of care issue today. My QOCC meets today. I request records today. I get them tomorrow, which is highly unlikely. I'm not even going to get it to our quality of care committee in time within the 15-day mark. Like, and that's like perfect case scenario. I get a complaint or a QOC issue, request the records today and get my records tomorrow. And I think that's where most of us are coming from on the traditional quality of care side. Like even in best case scenario, this is impossible for us. Unless someone has a quality of care committee that meets, every week, which I don't. I already had to get them to meet bi-monthly when we were just monthly. So I think it has nothing to do with me for, getting records, because even if I got them tomorrow, I couldn't have it turned around in 15 days.
So Courtney, that sounds more of like an operational issue. That's something that I would work internally to see if there's ways that those departments can meet more regularly to ensure that they meet that timeline. And
I think that's really hard to ask your subject matter experts to meet on a weekly. It was hard, it's hard enough to get your quality of care committee to meet regularly, and then adding now we would almost have to meet weekly to have it even a potential of having something turned around in 15 days. I'm sure we're not the only Ray with that issue.
So Courtney, can I ask, a lot of those cases that are a quality of care that, as you've defined it, are they coming from a member?
Oh, we get most of my quality of care issues come from either internal sources or other providers, unless they're referred to me by Dawn. So they wouldn't be your traditional, and I'm using air quotes, I know you can't see me, grievances. They're potential safety issues.
And they're reported internal. So you're receiving those internally, but who is the initial reporter of that incident?
It can come from anyone. They're typically a provider, or they're coming from one of our case managers.
Okay. That helps provide some clarity of how each plan and what their internal process is.
Yeah, if one comes from a member or an advocate, they go to Dawn and Lynn's team, and then if they think it's a potential safety issue, they refer it over to us on the quality of care side.
So in those cases,
around in 15 days would be next to impossible.
Right. For those specific cases that come from a member and then get transferred to the quality of care team as your internal process is, how long does that take to get those resolved?
Repeat that question.
For those instances in which the grievance comes from the member and then it gets moved to a quality of care, how long does that take to be resolved?
Well, and Dawn, I'm going to lean on you a little bit, but Dawn's team will stay within their required 15 days for grievances. And then I would take it on for the quality of care piece. And then that's when I can take it to my QOC, review records, and so on and so forth. So they would close theirs out, and then I would open that quality of care investigation.
When you say close it out, is this the case resolved?
I would have to defer back to Dawn. They do their grievance process, and then I do the quality of care investigation.
Yeah, so part of the resolution would be that it was transferred over to the quality of care department group to look into. So just
Thank
like
you.
Kim said in the chat, the grievance part would be have that resolution, it would be closed, and then it would move on to Courtney.
I see. I guess I would need more examples in that sense, because to me, it sounds like the case wouldn't be resolved and it's getting moved to the quality of care, in which the investigation still needs to happen. And if that's what I'm hearing, technically that's not compliant as what the rule has now, as getting that completed within the 15 business days.
Ellen, if I could interject, this is Catherine from Colorado Community Health Alliance. Yeah, resolution is a very strong, could mean any number of things. So when you remember that a grievance is an expression of dissatisfaction, the very first objective is to resolve the dissatisfaction, right? And so usually that means assuring the member has what they need, and that they know that we have the information we need to take care of what has happened. And so when a grievance is being resolved, it involves looking into the care, and if that process reveals, yes, something happened here that is a risk, that is a patient risk that we need to look at further. That is when a grievance moves into that level of investigation related to QOC, where we're now looking at standards of care and provider behavior that we might need to intervene in. So that is why in the statute, in order to resolve in 15 days, the resolution for the member is this needs continued investigation for quality. And then as the quality investigation continues, the other things you have to remember about this turnaround time is we have substantiated concerns.
Right.
So a substantiated and a leveled concern with a provider often proceeds to a corrective action plan. That provider needs to retrain, they need to rewrite policies in order to be cleared of their corrective action plan. So that is a significant amount of work, right? That could not possibly happen within these timeframes before a QOC could potentially reach that level of resolution, wherein the quality issue was identified, investigated, substantiated, corrected by the provider to the sufficiency that we believe the risk is mitigated and the issue is now settled. So that is what keeps people safe. And that is where we feel like any operational changes to somehow conclude that we've resolved things that we know are not actually resolved to the point of increased safety for our members is not satisfactory. We can't, abbreviate managing risk assurance in order to meet turnaround times.
And I completely understand that. And I do understand that those cases that are considered quality of care, in which, corrective, especially if they're substantiated, that require corrective action plan, that is not going to be resolved within the 15 business days. It may not even be resolved, quite honestly, in 90, right? Because there needs to be that follow-up that the corrective action plan was followed, and that they see the standards have been changed and policies and procedures have been changed. I do think this is still a process that is going to be evolving. We do just want to provide better clarity in this space. We understand how the current language in the contract, and by separating it out, has created confusion internally on what reports we're receiving and how the audits come to play and how we can combine those efforts. And this is our first initial attempt at this. I do think it's worth having further conversations, but we have had these discussions for about a year now, at least since I've been here, and we see that there is efforts that need to be done in this space to which we can get better insight on what's happening in these facilities and how we can improve member safety. I know the difference of the different definitions has created some confusion. I apologize about that, but it's a lot of work that's happening. We are open to have further discussions. We are, however, at a strict timeline for a contract amendment. We do want to start getting more insight on what's happening and starting to track more. And this isn't to say that this is something that can be changed in the future. Lynn, I think that's you that had that hands up.
Yeah, it's Marianne. I just wanted to add, so I really appreciate this discussion. And I just wanted to say that when I discussed this with my plan leadership, we had discussions around, like, we will be compliant with the contract by reporting back that our QOCs within 15 days are, for the most part, going to be unsubstantiated. So the state is just going to be getting a lot of these unsubstantiated QOCs. We will continue our investigation. Like, no matter how long it takes, we're going to keep investigating until we have an actual answer. So, but what it sounds like to me from what you're saying, Helen, is that's, I don't want to say that's the goal, but what you're saying is that that's okay, like that we are collecting data, and then when we go back to get the waiver for the 90 days, we would be able to sort of say, like, this is how many we cannot substantiate in this timeline. Is that right? Am I getting the right impression?
Yeah, well, I don't want to say it's okay to not complete investigations, especially those that are very easy to resolve grievances, right? And we do recognize, what I'm trying to say is we recognize that 15 business days is not a reasonable time frame to get everything done. We do want to track that what's happening. We do have a field internally within Salesforce that can monitor how many of these investigations require an extension. We suspect with the short time frame that is going to be asked of the plans that we'll be seeing that frequently. This is something for us internally and that we can use for the MSB to start to show that there is data to reflect that this is not a reasonable time frame. We do need to request an extension. We do need to have this moved up to 90 days to provide adequate investigations for our members. But it's not, I'm not saying that we want an extension for every single quality of care grievance. If this can be resolved within 15 business days, we want you to resolve them within 15 business days and follow standard process. We just recognize that 15 business days may not be a reasonable time frame overall.
That's fair. Thank you, Helen.
Mm-hmm. Greg.
Sorry, I had to come off mute there. I mean, I feel like several people have articulated kind of very clearly, like, especially when you start thinking about corrective action plans and providers and how we are keeping members safe and addressing concerns in our provider network while maintaining network adequacy, all these concerns that all of the rays have. This has been articulated very clearly why that's never going to be a realistic possibility to get that resolved in 15 days. But we're also being told that the contract tells us that we must get them resolved within 15 days. And I'm hearing you say that we understand that and we're addressing that and we're trying to articulate and tease out, well, we're really meaning, well, for the ones that can be resolved in that time, we want them to be resolved in that time. But I mean, to be blunt, the frustration and the stress that we're feeling over that is that's not what the contract says, what the current language says. And we're being asked to agree to a standard that is not required by the rule for these situations and is not going to be feasible. We're being asked to agree to something that we're going to be audited on and we are going to fail on. And so, I mean, I don't know what the solution is here. I mean, I hear you when you say we've been talking about this for a year. The feedback's been pretty consistent for a year, and we've not kind of addressed the foundational issues here in what we're trying to do. But we are being asked to sign a contract where we're going to be held to a standard that we know we aren't going to meet in these quality of care concerns for reasons that are important that we need to take that time to get these right and to do it thoroughly and do it right. I feel like we're talking past each other here when you're saying, well, we understand that concern, we appreciate that, and we understand it's not going to happen in these cases, but the contract requires it, that standard. And I understand that we can get an extension, but again, that extension, that's not what we're looking at here. So, I mean, I guess I'm just trying to say, I mean, if in a perfect world, from my perspective, this contract could be existing in almost exactly the same way that it is, but on that line where it says that where it says this 15-day requirement should apply to QOCGs, change QOCG to grievance. It can be silent on QOCs, and we can work on that going forward. But we're being asked to agree to something that where we're setting up our staff to fail. I'll stop now, but I feel like that point's been raised a couple of times, and we're not actually getting to progress here.
Thanks for that comment, Greg. I will say this is with the current contract as it is currently written, we do not have any insight of what is happening in the quality of care space. The only contract expectation is that if the department requests a case or investigation, that you have 10 business days to give that information to the department. So what this is our first step of getting information of what's happening not only in the grievance space but in the quality of care space or potentially significant patient safety issues. We understand that you have your internal process, but we don't know what is happening in the space for us to determine what's the most adequate time frame. We suspect that 15 business days is not going to be enough, just based on other experiences that we've seen in the past. But we don't have that insight in that quality of care space, and that is something that we need to get better understanding of what's going on. And I see another hand up.
Hi there, this is Lynn, and I guess I just had a clarification question. I know that in the Colorado guidelines that it says very specifically 15 business days to resolve a grievance. Are there, in the Colorado guidelines, is there a statement about patient safety issues that may be a different number? Because the last we had talked about the contract amendment, I think it was version 3, contract 18 version 3, said that there is 90 days to do both grievances and or patient safety issues. And I know that raised a red flag for us because we have to follow the statutes. And at one point, the state was going to get that amended with the Colorado state guidelines to match the federal guidelines of 90 days. Mm-hmm. And I guess and it was such a contrast to version 4 of like, now it's 15 for everything, where before there was there was a separation out of the timeframes related to patient safety versus grievances, which are not as concerning, for a patient's health and physical health issues or mental health issues. So I guess I'm just wondering, is it confirmed that in the Colorado statutes that there's the same timeframe for patient safety, quality of care issues as it is for grievances? I guess I was just confused with the change, like between version 3 and version 4.
Yeah, no, there isn't a specific call out on patient safety. It is the grievances as it's defined as in the federal regs. So any expression of dissatisfaction, and that can be patient safety as well, as long as it's not adverse benefit determination. So we did have it as 90 days for all, with the caveat that the emergency rule would be approved. And we did know at the operations meeting, I believe a couple weeks ago, that if it does not get approved, however, we are going to be following the standard rulemaking process to get that changed to 90 days. Hopefully that can be approved in the future. So that is where the change happened, I believe, from version 3 to the version 4 that you're referring to. It went from 90 days. The MSB did not approve of of the 90 days. So we are going back to what the Colorado rule has as 15 business days.
Can you share that rule for patient safety, which is different than, I think, that's, can you share that rule in the chat that we could research?
You mean the grievance and appeals?
No, the grievance I know because we researched the grievances, but again, there's a differentiation between a grievance and a patient safety quality of care issue. And so I guess I'm just wondering, does that statute refer to both of those?
I see. So there isn't the Colorado rule is specific to grievance and appeals, but we are following that. It's also the definition of grievance. So that within the federal regulations.
Okay, so but again, since we differentiate it in a quality of care grievance, that a grievance is listed as this, a patient safety issue is listed as this, and they're not necessarily, the one and the same. I guess I'm wondering, why are we applying such stringent days to the patient safety quality of care if it's not identified in the Colorado statutes?
I'm sorry, can you repeat that question for me?
Sure. If the 15 days is really related to grievances that are not related to, then then I'm wondering where did the interpretation come that 15 days had to be applied to patient safety or quality of care issue when they're kind of two different things, even in the definitions, it's two separate things. So I guess I'm wondering who made that decision to apply the 15 days to the patient safety issue.
Yeah, so what we found out is through the grievance and appeals deliverable, we did find that some of the reporting that was done around the grievance deliverable was technically considered a quality of care, but it was reported by the member, which would then default this as a grievance. So that is where that combination happened.
I think the fear is contracts tend to be bilateral. And in this case, you're hearing from, I think all the Rays have voiced that we will not be able to meet this contract demand. And we have put forward a solution that isn't being accepted, I understand, of just changing it to grievance, which then would follow rule and we'd all be okay. We do understand the tracking piece, and we feel like we could do some pretty robust tracking without having to make a contract amendment that we won't be able to meet. And that is largely our concern. There are other issues around notifications, around some of the rules that are the CRS that's listed. Some of that is actually incorrect in the amendment. And so we still do need to have a meeting in this next week.
Okay. I definitely hear you on that. We will work on getting something set up, and I appreciate all of your feedback. We understand that the time frame is a cause of concern, as well as other policy questions in this space. We would like to hear all of that out. I know we're over time, so Jerry, I will take this back to you.
Hey, thank you, Helen, and thanks everyone for the very interesting, important questions and feedback. Well, we are over the time limit. I did put a link in there in our medical services board on our online. You can go get in there and see the state rules. I put a link in the chat there real quick. Yeah, you may want to click on it real quick before we shut this off. So at this time, again, I'll try to get the draft minutes out and that link out as well to the forum. I think someone previously shared it in the chat as well. So with that said, Holly, I'll let you shut us down. Appreciate your help.
All right. Thanks everyone. Thanks, Jerry. Have a great rest of your day.
Hey, take care, everyone. Bye.
Thanks, everyone.
Thanks, everyone.
Bye.